This conference will now be recorded.
Good morning, everyone, and welcome to the August 2022 episode of the Animal Humane Society's Saturday Seminar Series. Today, we have with us Dr. Catherine Golden from Northern Lakes Equine Practice. Dr. Golden is a Northern Illinois native who graduated from the University of Illinois College of Veterinary Medicine with honors and then completed a rigorous equine internship at Carolina Equine Hospital in Greensboro, North Carolina. Her professional interests include ophthalmology, dentistry, preventive medicine, and sports medicine. She is an active member of the American Association of Equine Practitioners, traveling to meetings to teach veterinary students in wet labs. Dr. Golden also serves on the board of the Illinois Equine Practitioners Association, which focuses on bringing continuing education events to Illinois equine veterinarians. She frequently shares the continuing adventures of her adventing horse Spider, whom she has had for nearly 20 years, and her two dogs, Cora and Piper. Welcome, Dr. Golden.
Hello, thanks so much for having me. I'm excited to present to you guys this morning. Jen, it looks like, and maybe you have to share again. I know we ran through this, but it won't let me click the share screen. So,
Yep, there you go.
There you go.
All yours.
Perfect. Okay. All right. Let's see if we can get this going here. Hopefully, technology will be our friend today. It's always a little bit different presenting in a virtual format as compared to in person. I love being able to see everybody's faces and get interaction. But certainly if you have questions, please feel free to add them to the chat and I will be happy to address those as we go along. I love talking to people about everything equine medicine because I find that there's so much information with the, with the ability to have the internet and stuff available to us. It's always really fun to have the time to really focus in depth on a topic so that we can all get a better understanding. I don't know if again, hard when I can't see everybody, but I don't know if I've met any of you before or if any of you guys have heard me speak before, but I always try and do my presentations as though we're all going to vet school together because I find that that's the best way for us all to have an understanding. So that's going to be how our presentation is going to work today. So as you all know, you're here to learn about Equine Gastric Ulcer Syndrome. And again, I'm Catherine Golden. I am with Northern Lakes Equine Practice in Northern Illinois. See if the slide will advance. Go back, we'll get technology here. There we go. All right, so this is, let's see, can you pointer here? Laser pen, there we go. This is me in the upper left-hand corner because I don't know if you guys can actually see me or not. There's three doctors in our practice, myself, Dr. Laurel Meininger, and Dr. Kelly Mannion. We serve the Northern Illinois area. We do a lot of preventative medicine, dentistry, sports medicine, and of course we do gastroscopy as well, which is what we are here to talk about today. A little bit of an overview so you guys have an idea of where we're going to go, kind of how I spoke about in the beginning. We're going to start up here in vet school. Year one, you have lots of anatomy. So we're going to learn about the anatomy of the gastrointestinal tract first. Then we're going to learn how the normal GI tract should function. What does it do when everything's going correctly? We're going to talk about the prevalence of gastric ulcers, the different types of gastric ulcers, risk factors that can make some patients more prone than others. We'll certainly talk about clinical signs, diagnosis, treatment. And then at the end, we're going to focus a little bit on some bias around gastric ulcers, things that we can find on Google or Dr. Google. And then we're briefly going to touch on hindgut ulcers because that certainly is something I get asked about a lot. And I think there is some confusion that when people talk about ulcers, sometimes they're talking about hindgut ulcers instead of foregut or stomach ulcers. So before we begin, just to get some terminology out of the way, Equine Gastric Ulcer Syndrome is kind of our umbrella term when we are talking about gastric ulcers, and gastric being the stomach. Nothing with the hindgut, nothing with the large intestine, purely talking stomach at this point. Equine Gastric Ulcer Syndrome is our umbrella term that can be broken into two different types. We can have equine squamous gastric disease and equine glandular gastric disease. And unfortunately, some patients can have both of these, but we're going to go in depth into all of these as we advance on here. But sometimes it gets a lot to write out all of those names, and so you will see these abbreviations as we continue through, and I'll remind you of them as we go. So let's talk about the equine digestive tract anatomy. So the basic equine digestive tract, or the equine digestive tract, really starts at the back of the mouth when we swallow into the esophagus. So this long tube that runs down, it's a muscular tube that runs from the back of the mouth and moves a food bolus from the mouth into the stomach. The stomach is the second part of the equine digestive tract and is certainly going to be the main focus of our conversation today. Beyond the stomach, we have the small intestine, which is broken up into three different sections: the duodenum, the jejunum, the ileum. And then that moves into the large intestine, or the cecum, which is this large vat over here. This is similar to our appendix, which in humans is more of a vestigial organ that, as many of you are aware of, gets taken out sometimes. But in horses, it is an absolutely vital portion of their digestive tract. Then we have the large colon, which wraps around in many different kind of twists and turns. And on the next slide, we're going to watch a video of just how this works. And I really focus on anatomy because I think it is so important, not only to understanding gastric ulcers, sure, certainly, but colic. We talk about colic as horse owners, as horse advocates. Colic is something that, kind of strikes fear in all of us, and is not a term we ever want to hear, used in relation to our own patients that we care about. And so I like to talk about anatomy here, or pause here for a bit, because I want to make sure everybody understands how the equine digestive tract works, because it is not, very frequently I'll hear people talk about colic in, oh, my friend's horse had it this way and this is what they did. And there's so many different types of colic that it's really important to understand the differences, so that we can pick the best treatment. So that's where we're going to focus here a lot on the anatomy itself. After we go through the large colon, we've got the small colon, which is broken into the transverse and the rectum, and then poop would exit through the rectum. So just some kind of interesting facts. The horse's GI tract is around 115 feet total. That's basically enough to go from home plate around first base and partway to second if you stretch it all out. So it is a very long tract that is all folded in on itself in various ways. The total transit time from a food bolus that's swallowed until it makes it to the other end is typically between 36 and 72 hours. And so we all talk about, like in colic, if the horse poops, we feel better that we've seen manure come out, but a single poop does not always mean the all clear, because there is lots and lots of transit time. We need consistent manure piles before we feel good about that. On our next slide here, there's going to be a video that I'm going to play. This video is available on YouTube. It's one of my favorite things to pull up when I'm stall side with patients and I have a patient colicking, just to give people an idea of where and how the GI tract is folded up so people can visualize a little better. So I'm going to play this video here, and there is some sound with it, so I will stop talking as the lady kind of describes us through.
The stomach is positioned primarily on the left side of the cranial aspect of the abdomen. From the stomach, the ingesta moves into the duodenum, which is attached to the dorsal body wall on the right side of the abdomen by a short mesentery. At about the level of the horse's flank, the duodenum changes direction, turning to the left. Just after it crosses the midline, the mesentery supporting the duodenum lengthens considerably, demarcating the transition to the next part of the small intestine, called the jejunum. In the normal adult horse, the jejunum is about 70 feet long. To simplify the situation, this entire length has not been incorporated into this model. The last part of the small intestine is the thick, muscular ileum. The ingesta moves through the ileum and into the cecum, which is positioned primarily on the horse's right side, extending from the right flank region to the sternum. Ingesta then leaves the cecum and enters the large colon. It enters the right ventral colon, moves around to the left ventral colon, then up into the left dorsal colon, and finally back around to the right side into the right dorsal colon. From there, the ingesta passes through a short transverse colon and finally into the small colon where fecal balls are made. Undigested waste material leaves the body through the rectum.
I just think that's a great video for many different reasons. It kind of briefly walks us through, excuse me, the entire GI tract. And I just want to point out here very quickly, some of these very tight twists and turns. You can see all the spirals and the loops and the back and forth that the ingesta has to move through. And it's just amazing to me, all the narrowing ways that that the food bolus travels through as it moves through the GI tract. And it's no wonder that we oftentimes see issues arise.
Here's the right ventral colon.
Pause that. We're going to go to our next slide here. Now we're going to start specifically talking about stomach anatomy and the equine gastric anatomy. So the very first part of that video was the stomach. And so again, we have our esophagus that empties into our stomach right here. We have the entirety of the stomach, and then our exit of the stomach over here is the pylorus as we start into the first part of our small intestine. One of the main things that we need to point out here are that there are two very different tissue types in the stomach. We have squamous epithelium up here, which is in this picture here, this kind of yellowy or lighter colored. In this lower film here, this lower picture here, this light pink tissue here. This is squamous tissue. So because we are all humans and it's easy to think about things in terms that we can understand or relate to ourselves, our entire esophagus is made up of squamous epithelium. Our entire stomach, the human stomach, is made up of this glandular epithelium. But you can see in the horse that actually about half of the stomach is made up of squamous tissue as well. When we start talking about gastric ulcers, gastric squamous ulcers in particular, we're actually talking about something that's very similar to what humans feel when they have heartburn or acid reflux back into their esophagus. That's kind of how squamous ulcers feel in the horse. If we're anthropomorphizing a little bit there, those are the same tissue type. So the stomach, the glandular portion of the stomach produces stomach acid. This is what helps to aid in digestion. And there's this very fine demarcated line here called the margo plicatus. You can see it very easily in this image here. You can see it very easily in this image down here. This is the line that separates the glandular tissue from the squamous tissue. The glandular tissue produces acid, and thus it has normal protective mechanisms to make it so that it is not harmed by the acid it is producing. However, the squamous tissue does not have those same protective mechanisms, and so when it comes into contact with gastric acid for prolonged periods of time, that is when we see the traditional squamous ulcers start to form. And it's very easy to see when you look at these images and you look at the anatomy, how that can happen very easily and very commonly because there's really not much physically separating the two locations. So now we're going to talk a little bit about what is the purpose of the stomach. What is the normal physiology that the stomach provides to us? So it is a holding vat. It essentially takes the food bolus, keeps it in an area as we start chemical digestion on it with the hydrochloric acids and different pepsin and organic compounds that are within that stomach acid. There's minimal absorption in the stomach. Most everything has to get passed into the small and large intestine for digestion to start taking place. Horses are basal gastric acid secretors. That means that regardless of whether they're eating or whether they're not eating, they are constantly producing gastric acid, up to 16 gallons of gastric acid a day, which is a large amount of acid. Normal chewing patterns create saliva. And on our next slide, we're going to go through how much saliva the horse can produce. But essentially, it's around 15 gallons a day. Not only do we need saliva to help us swallow and make the food bolus more comfortable as it's going down, but in the horse, it's critically important because saliva is a natural buffer. It's a natural low acidity. So it kind of takes the gastric acid and it mixes with saliva and makes it a more comfortable level for the stomach itself. And so it creates a little bit, part of that protective mechanism. And forage is vital for chewing. So we'll look at that here. So in a grazing horse, the normal grazing horse that's outside, you know, in the wild, or horses that live on pasture 24/7, good lush pasture, are typically chewing about 60,000 chews per day. Horses that are eating hay at the recommended 1.5 or 2% body weight are only chewing about 25,500 chews per day. Then if you take those same patients and you look at them and you only are feeding them a grain meal, you can see how drastically the number of chews per day decreases, because obviously we know we don't have to chew as hard or chew as much to get the grain broken down as we do hay. Obviously, this is, we're speaking in a normal, healthy horse. There are certainly cases of patients that are unable to chew hay as they've aged and some of their teeth have gotten to a point where they can no longer safely chew hay. So we are talking about in this slide here, the normal, healthy horse that has appropriate dentition and can chew. So prevalence, it's easy to see why there is a large prevalence of gastric ulcers in our domesticated population of horses, because anything that affects their normal functions can predispose them to developing ulcers. So there's many studies out there trying to look at the number of horses in different populations that suffer from gastric ulcers or equine gastric ulcer syndrome. Typically, studies range between 30 and 80%. Endurance horses are overrepresented because of the time frame that they are being ridden for. The stomach has time to empty, and then we have a prolonged period of time where there's not food in the stomach, and thus the gastric acid is able to splash around. So we see a higher percentage of gastric ulcers in horses that have prolonged periods of time. So lots of sport horses, racing thoroughbreds, you know, the sport horse population is certainly overrepresented, but we also can see it in stabled horses as well, which we will talk about. So we've talked about the two different types of ulcers, squamous and glandular. Again, glandular being this dark pink tissue down here. This is also glandular tissue down here. This is the exit of the stomach. That's the pylorus. So if you remember back from our first picture here, that little circle that we were looking at, that is the pylorus right here. So we have two different types. Our squamous, you can see we've got some lesions around the margo plicatus right here, some ulceration. So these are squamous ulcers, and these are glandular ulcers. Typically, glandular ulcers are found around the pylorus, although there are certain exceptions where we will see them in this darker pink tissue around here as well. What are our risk factors for developing gastric ulcer syndrome? Anything that alters the normal physiology of the patient can allow us to create an environment where gastric ulcers can thrive. So eating and feeding programs, patients that are fed very episodically, meaning they get a morning feed and an evening feed, but throughout the day they don't have forage available to them, or overnight they go periods of time where they don't have hay in front of them. This certainly will predispose them to developing gastric ulcers, because we have periods of time where there isn't that protective food barrier in the stomach. In some disciplines, we have a removal of food prior to working, and this will also predispose us to getting gastric ulcers, because we have the ability then for the gastric acid to splash up into that squamous portion as we are working. Certainly diet selection, where we talked about the number of chews, whether we're eating forage versus grain, can absolutely make a difference. Decreased grazing time. And we also talk about stress. So stress is a very difficult thing to measure in the horse, because what's stressful to some horses isn't stressful to others. Some horses are stressed by being outside and having the flies bother them, and other horses are stressed being in a stall when they can't be outside with their friends. And so it can be a little bit difficult to determine in each individual patient what is stressful to them. But certainly we know that things like transport, changes in stabling, and herd dynamics are three common things that can cause physiological stress in the patient. Certainly pain, so horses that have a chronic lameness or a chronic eye condition or cellulitis or a skin issue or something that's causing them physical discomfort will also raise those stress hormones in them and can then predispose them to developing gastric ulcers because the normal mechanisms of the body aren't functioning correctly. And then we also have different medications. So things like non-steroidal anti-inflammatories, butanamine, efiroxib, things like that will change the way that the normal physiology of the stomach works and thus can predispose them to developing ulcers. But essentially, go back to just the blanket statement that anything that alters their normal physiology can predispose them to developing gastric ulcers. Clinical signs are very wide and very variable. There are plenty of patients that will develop mild intermittent colics, especially after eating a grain meal. We can see some patients have a low level inappetence where they just seem to be a picky eater or aren't excited about some of the food options provided to them. Some patients will exhibit weight loss. Some patients will have an unthriftiness or where their coat just isn't quite as dull, or they're not gaining weight despite the amount of food that's being fed to them. We can see behavioral changes when we're girthing or under saddle. And then there certainly are a subset of patients where we don't see any clinical signs. Some of the worst ulcers I have actually seen in horses have been in patients where I was there scoping a horse that did have clinical signs, and someone was like, hey, I want my horse to get done too. And we've done the horse that had no clinical signs or seemingly no clinical signs and found ulcers in them. So I think it's also important to note that sometimes we don't see a large reaction or a large clinical sign from them. We're going to talk now about the squamous stomach specifically, because these are our kind of our classic or traditional type ulcers when we talk about equine gastric ulcer. So again, the squamous stomach, this is where we're talking about equine squamous gastric ulcers. The squamous stomach is very similar, like I spoke about already, to the human esophagus. And so when we experience heartburn as humans, that is similar to the feeling that patients get when they have squamous ulcers. So in humans, we call it gastric esophageal reflux disease. And it's basically exposure of this squamous tissue to gastric acid. And this squamous tissue has minimal protective barriers to protect it from the acid. And so that's why we will see, in humans, we will see it when we have breakdown of the sphincter here, but in horses, there is no physical barrier there. So prolonged periods between meals will cause more acid to splash up into this area. Foods that increase the acidity, so things like high grain meals, make the acid that is normally in the stomach more acidic. We will see patients that are on low forage diets that don't have this protective food mat in their stomach get ulcers more frequently. And then if they're not chewing, if they have a low forage diet and they're not chewing, we have decreased saliva buffering. So again, this is just kind of going through what we just spoke about, but just written out here a little bit. It is a direct, squamous ulcers are a direct result of increased exposure to acid or an empty stomach or a less full stomach than they should have. And it's incredibly important to note that even though there are medications that we use to treat ulcers, treat squamous ulcers, dietary and environmental modifications are massively important, because if we put them on medication that decreases the acidity and makes that caustic acid less caustic, as soon as we remove that, if we haven't changed the trigger, if we haven't changed the environmental conditions that are allowing these ulcers to form, we're just going to see ulcers form again. So these squamous ulcers are graded on a scale of 0 to 4, 0 being no ulcers, 4 being severe ulceration or diffuse ulceration. And on these next slides, we're going to run through what the different grading scales are. So grade 1 squamous ulcers are, think of it, I like to think of it as when you put on a new pair of shoes that you haven't worn before and you walk, you start to get a callus forming because of the friction, because of the trauma to that area, you start to get a callus. And so grade 1 squamous ulcers are kind of the callus of the stomach. You can see this yellow staining all through these two images here. That is gastric acid that is staining the epithelial cells up there. And the body is trying to lay down more epithelium, make a callus, a hyperkeratosis, to try and protect itself from this exposure to the acid. And so type 1 ulcers is not actually a physical defect where you would think of your traditional, like missing tissue. It's actually more tissue as the body is trying to protect itself from the acid that it's exposed to. Grade 2 squamous lesions are where we actually have a defect in the squamous epithelium. So they're typically small, usually just 1 or 2 of them. You can see in this image up here on the left, we actually have grade 1 and grade 2 ulcers, but we always grade the stomach as a whole based on the most severe lesion. So we would call this grade 2 because even though we have all this hyperkeratosis through here, we also have true defects or breakdown in the epithelium itself. And so by definition, we would call it a grade 2. Grade 3 lesions, and I'm hoping, let me see if I can, there we go. Grade 3 lesions are larger lesions or more diffuse lesions. And so you can see that we have multiple lesions here that are exposed, and thus we would call this grade 3. And then grade 4 is going to be our most severe. I don't know why my stopped moving here. Give me 1 second. Come on, there we go. All right, grade 4 lesions are very severe, oftentimes bleeding. They're large defects, multiple kind of throughout the stomach. These are grade 4 lesions and are our most severe. The treatment of squamous ulcers. So we are specifically talking about just squamous ulcers here. No, we're not talking about glandular yet. We are just talking about squamous. So the traditional proton pump inhibitors, these decrease acid secretion. So omeprazole is our kind of hallmark medication that we use in horses as a proton pump inhibitor. And essentially what omeprazole does is it decreases the acidity of the acid that is there. So it's taking the normal acid and it's just making it less acidic. So it's not doing anything about where it's touching or preventing it from touching places it shouldn't. It's just saying when this acid touches a place that it shouldn't, it won't be as caustic to those tissues. The important thing to recognize about omeprazole is that it's not absorbed in the stomach. It's absorbed in the small intestine. And so it really, to be effective, needs to be fed on an empty stomach so that it can get into the small intestine, be absorbed into the bloodstream, then travel back through the bloodstream to the blood vessels that are feeding the stomach to allow the cells that produce acid to produce a less acidic acid. So it has to travel quite a ways. There is also a rebound effect with proton pump inhibitors, or we suspect there is. We know there is in humans. It hasn't been as well proven in horses, but certainly it seems anecdotally to have the same effect, which what this means is patients that are on omeprazole for extended periods of time, we don't just want to stop it cold turkey, because if we do that, the body then has this effect where all of a sudden it produces more acid because its inhibition has been taken away, and thus we will sometimes see worsening of ulcers or worsening of clinical signs if we just stop omeprazole without weaning them off of it. Other medications that are sometimes talked about are these H2 receptor antagonists, things like ranitidine, famotidine, cimetidine. These are used in humans quite a lot. They're not quite as effective in the horse, and the dosing of them is a little bit more tricky because it needs to be done every 8 hours. And as we all know, syringing medication to patients every 8 hours is not fun every 24 hours even. So it makes it a little bit more difficult. Sucralfate is another product or another medication that we will talk about and that we use a lot with squamous ulcers. It basically forms a protective barrier, but it will inhibit the absorption of other medications. And so we never want to give sucralfate at the same time as we're giving omeprazole, or at the same time we're giving them their antibiotics if they're on antibiotics for some reason, because it will prevent the absorption of many other medications. And so the timing of the treatment of these medications is vital to the success of treating the disease itself, because if we give them all at once, we give them on a full stomach, we will see a much decreased favorable response. People will also talk about pectins and lectins. These are in a lot of the supplements that are out there. Some studies show that they are helpful. Some studies show that they are contraindicated. I certainly have lots of patients that use them with some success, and so they do exist on the market. Natural buffers, so things like alfalfa. Alfalfa is essentially nature's Tums. It has a really high calcium phosphorus ratio. And so when we're speaking specifically about treating squamous ulcers, alfalfa can be helpful. Now, alfalfa is not perfect in and of itself, and you know, there are some patients who are not tolerant of it or who have other GI disturbances as a result of alfalfa. But if we are specifically talking about the treatment of squamous ulcers, alfalfa can be helpful. And then certainly dietary and environmental modifications are vital to use with our different medications, because that is going to be the foundation of prevention of ulcers and recurrence of ulcers, is changing those environmental factors that have allowed them to come to fruition in the first place. We're going to switch gears a little bit here, and we're going to talk about the glandular stomach. So again, I'll scroll us back here just so we can all be on the same page. Glandular stomach, everything we've just been talking about is all up here, the squamous stomach. Now we are going to focus down here on our glandular stomach. So glandular stomach is, again, similar to the human stomach. It is meant to secrete gastric acid to help digest or start the chemical breakdown of food. Again, horses have this basal secretion. That means constantly throughout the day, whether they're eating or whether they're not eating, they are creating gastric acid and they are secreting it into the stomach. Glandular ulcers thus are a result of the breakdown of the protective barrier. So in squamous ulcers, they're a result of the acid touching tissue that it shouldn't touch. In the glandular stomach, it's meant to touch that acid. So we get ulcers in the glandular stomach when there is a breakdown of the protective barriers. And the protective barriers are things like mucus that is normally secreted from these tissue cells as well. And so once that barrier is broken, then it allows exposure of the acid to tissue that is no longer protected, and thus we get ulcers that form here. Glandular ulcers are poorly responsive to proton pump inhibitors. So traditional ulcer therapy, omeprazole therapy, does not seem to have any major effect on glandular ulcers. And this is one very important distinction, because so frequently we'll get presented with patients that I am told have been treated for gastric ulcers with traditional omeprazole therapy without a gastroscopy or a scoping being done. And they're like, well, we know it's not ulcers because they didn't respond to treatment. And so we're looking for what else could be going on. But unless we have a scope to show us what type of ulcers we're treating, we don't know that it didn't respond to treatment. We might just have been picking the wrong treatment. And so I think that's a really important takeaway from here, is that glandular ulcers do not respond to the normal omeprazole type therapy the same way that squamous ulcers do. So blanket treating with omeprazole, you're missing a large subset of ulcers that could be causing clinical signs. So this is just a little schematic of essentially the blood vessels that come. This is where our medication that's absorbed comes back to the stomach lining and then takes effect on these gastric glands, and thus allows them to secrete either an acid that is less acidic for treating squamous ulcers, or in the case of the medications we'll talk about for glandular, changes how the cells that secrete their protective barrier function. So one of the main medications that we use to treat glandular ulcers is something called misoprostol. This allows the protective barrier to remain intact. And thus we are able to treat glandular ulcers by creating a protective barrier. So these are some images of different gastric glandular ulcers. You can see that this is, again, the dark hole here, and all of these is what leads to the small intestine. There is no grading scale at this time like we have with squamous ulcers, 0 being no ulcers, 4 being severe. In glandular ulcers, we describe the lesions themselves. So we would call this like a raised fibrinose-separative lesion, where you can see we have this kind of little plaque of fibrin here, little bit of dark brown staining tells me that it's bleeding a little bit. This lesion down here has a little hyperemia to it, kind of multiple punctate little places there. And so we describe the lesion versus grading it in terms of severity. There is a lot of speculation and research showing that glandular ulcers are very related to stress or increased resting cortisol levels. And like we talked about in the beginning, what's stressful to an individual patient is sometimes hard to know, but we know that stress will cause us to see an increase in glandular ulcers. Non-steroidal anti-inflammatory use has variable effect, but likely will decrease the protective barrier, because the way that non-steroidal anti-inflammatories work is they target the cells in other areas of the body that are also present in the stomach that produce that protective mucus. And so when we're on a non-steroidal, our mucus production, or that protective barrier of the glandular stomach, is decreased because of the effect of the non-steroidal. In humans, there's a lot of talk about Helicobacter pylori as an infection that causes a breakdown in the protective barrier in human stomachs. We have not found the same correlation in horses. There have been lots of patients with glandular ulcers where they've sampled tissue and looking for Helicobacter, and in plenty of patients without glandular ulcers, we are able to find Helicobacter, and in plenty of patients that have glandular ulcers, they don't find it. So there really at this time is not a strong correlation between Helicobacter causing glandular ulcers. There is a large correlation in humans, but that is certainly not my area of expertise. So in horses, we do not see the bacteria to be a problem. So environmental and management conditions to treat both or to take effect on both squamous and glandular, the more we can return the stomach's physiology to how it was meant to function, the better we are at preventing the formation of these ulcers. So the more access to free choice forage we have, whether that's through turnout or through hay that is provided in a slow enough feed rate, will help keep a food buffer in the stomach. Certainly always having access to free choice water, the calcium phosphorus ratio, and the alfalfa hay, limiting grain concentrates as much as we can, and then being judicious with our use of medications, because certainly we need to make sure we're treating other conditions that are underlying, but we know that there is correlation between overuse of medication or even appropriate use of medication can have an effect on the way that the stomach is functioning. So we are going to get a little bit into the meat and potatoes here of what gastroscopy is. So a lot of these images that I've been showing you are taken through a gastroscope, which allows us to differentiate the use of ulcers and allows us to differentiate between the types of ulcers and tailor our treatment to them. So again, we don't want to just be blanket treating, because if we have glandular ulcers, we need to be treating in a different way than we would for a squamous. And so gastroscopy is a minimally invasive procedure. Most patients tolerate it quite well. It allows us to visualize what is actually there, but it also allows us to monitor our response to treatment. Because our clinical signs can be very vague in some of these patients, they might not actually be related to, if we're having a behavioral issue under saddle, is it actually because we have a gastric ulcer? Or is it because we have a performance issue coming from pain somewhere else in the body? And sometimes we have to look, see that we have an ulcer, heal the ulcers, prove that they're healed on gastroscopy. And if that performance issue is still ongoing, now we need to look for other reasons for that performance issue. This is a sped up video of a gastroscopy here. Let me see, I need to get rid of this arrow. I don't know, some people get a little bit car sick, and there's some motion here. So I hope it doesn't make anyone feel ill watching through. You'll see we're traveling down the esophagus right now. The esophagus is a collapsed tube, and so that's why sometimes we lose visualization as we're going through it. So the first thing that we do as we get into the stomach is I blow air into it. So we've got glandular stomach on the right side, squamous stomach on the left side. The dark line the line in between is the margo plicatus. We've got these folds in here. They're called the rugal folds. So the first thing that we do when we get into the stomach is blow it up like a balloon. because we need to expand all of those out so that we can see all of the margins. Now you can see that we've come in our view right here. That's our scope coming in at the cardia, so the esophagus entering into the stomach, and then we wrap around so we can see all of the tissue. We go to the exit of the stomach first because it's the lowest part, and if we start pumping water in here, we will not be able to see. In order for a gastroscopy to be performed, patients have to be fasted. So you can see we've driven here to the pylorus. This is where we exit the stomach through that black hole there, goes into the small intestine. And so we have to have patients with a really empty stomach to be able to see all of these things. Otherwise, when we get in here, there's food everywhere and you can't see these different structures. We always go to the exit first, see some nice peristalsis, normal contractions of the stomach. We lose visualization as we kind of come back through the soup here. And now clean off our windshields. And now we can start looking at the squamous tissue to see if we have any ulcerations here. We use a little, what I call the squirt gun, to kind of rinse off any food material that's still stuck there. You can see we have an ulcer right there. We're gonna rinse off in a couple other places. We have some ulcers over here. One of my favorite things about gastroscopy is it's very black and white. They're there or they're not there. So many things are not black and white, but this is something that is. And so I'm gonna pause, come back here just a second. I'm gonna pause right here. You can see this acid, how this patient is fasted, right? Because we're doing a gastroscopy. You can see how on an empty stomach, we have all this acid and it's splashing up onto this squamous tissue. And so in a fasted patient or a patient that just is not eating enough, this acid comes into contact with this squamous tissue so frequently, and that is how we get squamous ulcer formation. Before we leave, we empty out all the gas we pumped in, so that since horses can't burp, we want to take all that gas out. So this is just me emptying the stomach out. You can see it collapsing down here on us, and then we back on out. That's kind of a quick look at the scoping. So I'm just going to show some images here of different gastric ulcers. These are squamous lesions. This is an area at the lesser curvature of the stomach. It's an area that sits in very close approximation to the acid line, and so we very frequently see. I realize I don't have my laser pointer on. Get back here. We very frequently will see ulcers in the lesser curvature area because it's so close to that acid level. You can see up here all these bleeding ulcers along this lesser curvature here at the cardia, and here is the scope coming in at the top. Got some other just pictures here. Get this from up. Here's another just quick video of a patient that has some pretty severe ulcers. You can see how they're bleeding through here. Push forward here. This patient also had some glandular ulcers as well. So very frequently we will see both types of ulcers in a single patient. Sometimes we will see just one or the other, but it's important that we address both. So this is that image from that patient there, but you can see all these bleeding lesions here. So this patient was very uncomfortable. To our next one. I think this is a fun little image here. We have some bot larvae here. So these are bots zoomed in here. There's a whole party of them over here. There's probably 15 or 20 of them. They can grab onto the squamous tissue, grab onto the glandular tissue. I rinsed them off, and that's why you can see this bleeding trail here. And it's easy to see why bots can certainly cause some irritation to the stomach lining, and important use of dewormers. This video up here that we're about to watch I like it because it kind of shows the anatomy of the upper airway where we started our GI tract discussion going into the esophagus. This is our epiglottis. These are our arytenoids. I realize I don't have my laser pointer, I'm so sorry. This is our epiglottis. These are our arytenoids. This area right here is the trachea, and our esophagus is over in this corner. So as I play this video, we'll get closer to where it is, so you can see that it's, as they swallow, where our tube has to go, where our camera has to go. So we don't want to go down the trachea. That will take us to the lungs. That's not our intended place. But just in that right-hand corner next to that arytenoid is the opening to the esophagus. And so that's where we drive our camera. As we go down there, it'll come here in a second. It's you can barely see it. It's just that little slit there. And then the patient will swallow. This is when we're tubing for colic. This is the same area that we're going right there, and the patient swallowed, and now we are in the esophagus. We lose visualization for a little bit as we travel down, and then we get into the stomach. This one at the end, well, I'm gonna zoom out here. Oh, we've got some of our little bot friends. You can see how they hang on there. Come here. Just trying to rinse this one off, and he wanted to hang on. They're just stuck there. So dewormer, we'll get those gone if we can't rinse them off. All right, our next slide here. All right, so I just want to talk just briefly about bias and legalities and stuff like that, because we haven't used any brand names or product names here, because that's not really what this discussion is about, although I don't think we can talk about gastric ulcers without at least talking about the products that are available on the market. And so omeprazole is the drug name or the active ingredient in GastroGuard and UlcerGuard. I do not work for BI, the company that produces it, and so I don't have a bias in that sense. However, GastroGuard and UlcerGuard are the only FDA-approved omeprazole products for the prevention and treatment of gastric ulcers. And so because there is an FDA-approved product on the market, legally as veterinarians, we should not talk about using compounded medications. Compounded medications outside of omeprazole have a host of issues as far as regulation, but this was an interesting study over here done by Dr. Mark Wallace, actually at Carolina Equine Hospital, where he just purely was just taking x-rays of different omeprazole products. This one down here is GastroGuard, one's up on the top, and you can see all the air pocketing and things like that in the compounded products as compared to the FDA-approved product. And the reason that that's important is it just shows that sometimes what's in the tube is it's not a full tube always. You just don't always know what you're getting. The other thing that can be difficult with omeprazole in horses is that it is not terribly well absorbed. As we talk about, it has to go through the stomach and get into the small intestine before it's absorbed. And it's actually not omeprazole itself is not terribly hardy. And so it needs to make it through the acid of the stomach to get absorbed. And so when we prove what GastroGuard and UlcerGuard had to do to get their label claim is they have to prove that they're making it through the acidic environment of the stomach to be able to be absorbed. You can feed lots and lots of omeprazole, but we don't necessarily know if it's getting through the stomach acid and being absorbed to be able to have effect. And so it is just a point I want to make that just because we're treating with omeprazole, if it isn't in the formulation that can get through the stomach and absorbed, we don't necessarily know if we are getting an appropriate effect. I put these two specific pictures in here because these are from two different patients that were, I scoped for ulcers that were on a commonly used over-the-counter medication, and they had been on that for a very long time and clearly still had very severe ulceration. And so I always, the main takeaway from this particular slide is that unless we have scoped to look to see what is in there and we are actually treating with a product that we can come back and follow to prove that it's working, I don't ever want people to say, I treated them for ulcers, so I know it's not ulcers, because unless we've actually looked, we don't know. All right, let's get to our next slide here. So I always like to talk a little bit about Dr. Google. We all do it. I Google things too. If I find something, if I'm concerned about something on myself, I'll read about it. And I very much think that arming yourself with knowledge is important. We are so lucky that this day and age we have the internet available to us that we can read. I fully support when my clients read on Google. Do it. I like it. But be mindful of the source. Just because it worked for one patient or one individual does not mean that that is what will work for every patient. There are so many different things and factors in individual patients. So absolutely read about it, but be mindful of the source. And I like to take this time to also talk about establishing a relationship with a veterinarian now that you trust. Use vaccination and wellness appointments to get to know your vet and for them to get to know you, so that you guys can have these discussions, whether it's about gastric ulcers or lameness or ocular issues, whatever it may be. Having a relationship where you guys have good communication back and forth is vital, not only for treating ulcers, but for treating everything in the health of the patient. I'm going to talk super briefly here, we are almost done, about hindgut ulcers, because lots of times people will ask if we can visualize hindgut ulcers, and unfortunately not. If you remember from that video we watched at the very beginning, the hindgut ulcers are hundreds or 100 feet, 30, tons of feet away. We have to go through all of the small intestine before we even get to the large intestine. You would have to go through the cecum, come out the cecum, and come into this right dorsal colon here. This is where we see hindgut ulcers most commonly. Hindgut ulcers get blamed for a lot of things because we can't prove that they exist or that they don't exist. We are unable to visualize this area with any form of endoscopy. You can't go in from this way, you can't come in from this way. There's nothing that can actually get to this area of the right dorsal colon to prove the existence of these of hindgut ulcers. Hindgut ulcers are oftentimes the result of very long-term medication combinations. And so while hindgut ulcers certainly exist, and I'm not saying that they don't exist, I think they get over-blamed for various performance issues because we can't actually prove that they're there or not there. And so they are a diagnosis of exclusion. We need to rule out other things before we call it a hindgut ulcer. So I will leave that there. They are different than gastric ulcers, which we have been talking about this whole time. So at this time, I will open it up to some questions. We are just a little bit of a plug for our practice, or just for social media more than anything. We love to post, our practice loves to post educational videos on various topics. So on our YouTube channel, we've got, how to do foot wraps and bandaging and just various things that you might find interesting, how to safely take temperature on a horse, things like that. Certainly you can like or follow us on Facebook and Instagram. We try and post educational, but also fun things there. So does anybody have any questions that I can answer for you? Hopefully we haven't glazed eyes over too much. And if not, or if you think of things after, I think Jen probably has my contact information. You're always welcome to contact me that way as well.
If you want to toss it back to me, we can put that.
I got a couple dumb questions. I'm usually good for a couple.
Okay.
When you're talking about it has to get to the intestines in order to be effective, from your veterinarian side, do you ever take the medication and take it to the bottom part of the stomach? I can't remember the term where
the pylorus.
And then place the medication there. Is that even possible, or?
So yes, but it would require that the patient be, sorry, let me start over. We do not do that. I suppose, yes, it would be possible to do, but it would require the patient to be sedated, tubed every time you were trying to dose that medication. So it wouldn't be a practical, it would not be practical dosing, I guess.
And so typically when you treat with that, I can't pronounce it.
Omeprazole. You got it.
So it's more like a antibiotic. So it's going to be given several times for several days then.
Yeah, so omeprazole dosing is recommended to be given. And the reason I didn't talk specifically about how to give or when to give is because that really needs to be a discussion between the treating veterinarian. But in general, what we do is we give omeprazole on an overnight fast, because like we've been talking about this whole time, we don't want the stomach to be empty for too long, because that gives us a predisposition for ulcers. But we also want to give omeprazole on a relatively empty stomach, and that conflict is sometimes hard to wrap our head around. So what I usually tell people is very first thing in the morning, horses tend to self-fast, even if they have hay available to them 24/7. They tend to self-fast between the hours of like 3 and 5 a.m. There have been plenty of studies where they've put cameras in and watched this happen. And so I like to tell people, very first thing in the morning, come give the omeprazole product on what should be as empty of a natural empty stomach for the patient. Wait an hour before the patient is fed anything else, and then we can feed after that, because we don't want to give omeprazole in a patient that has high hay or forage in their stomach right then, because it won't get absorbed as effectively.
Okay. And you're saying really hay, grazing, 60,000 chews a day is really what that horse needs. So when we're feeding grain only or whatever, we're really cutting out quite a bit of that for that particular horse. And I've had this discussion with my sister when we have some that are pleasantly plump, let's call them.
Yeah.
So in the evening, you know, she feeds twice a day, small amount of grain. Of course, they're in the pasture during the day, but in the evening, she would want to put them in a stall without even any hay. So, and I know you said it's 36 hours from start to finish when it goes through the whole system,
Mm-hmm.
but stomach wise, they've got to have that forage. How often? I mean,
yeah, the stomach really, it really empties in about 2 to 4 hours. When we're actually scoping patients, we truly need them empty. We fast them for 12 to 18 hours before we scope them. But the average, like just patient just functioning day to day, their stomach typically empties in about 2 to 4 hours. And so for those patients that are really easy keepers or pleasantly plump, we like to find forages that are really low in calories but are high in fiber. So some people feed straw, and straw has no nutritional value. It's very low in calories, but it has a huge value in chewing and creating saliva, as well as creating that physical food mat buffer in the stomach. So very low, like your low quality kind of stemmy hay that you wouldn't want to feed for nutrition of other nutrition, but just purely to have physical food in the stomach is actually really wonderful for those patients from like an overnight perspective, or for horses that are easy keepers.
and I'm assuming like a slow feed bag versus just, you know, a regular hay bag or whatever.
Absolutely. So slow, there's a lot of discussion about nibble nets or different types of feeding environments. But yes, anything that you can do that slows them down and mimics a more natural foraging type behavior, so they're not just, because a horse with great teeth and that's hungry can take a whole flake of hay down very quickly, and then you've got a whole hours where they don't have food in front of them. So it absolutely becomes a balance of slowing their consumption down enough that it's spread out over a long period of time. So yes, absolutely, I do like using versions of slow feeders.
Well, thank you. You've been very informative, and I'll conclude my dumb questions for the day.
No, those were excellent questions. Those really were wonderful points, and I'm glad you brought them up. So thank you.
Hi, Dr. Golden. I had a couple questions.
Hi.
So I lived in Ramona, California, and most of the horses I was helping with, they were all stalled, and they had turnout pastures arenas, but there was quite a few that had dealt with ulcers. So I was curious as to your seminar to learn more, and a lot of them they would have me make grain and add bute, and would that almost make it worse? You think? Now that I'm looking back, I'm like, it seems like they just would switch all their diet all of a sudden and then have me give them only alfalfa and make more grain for them with bute in it. And I'm like, I'm looking back thinking maybe that wasn't the best options. And I mean, they're obviously getting, they had their vets, but you had a lot more information in your seminar that I'm like, okay, that makes a lot more sense, or having complete access, because they were only fed early morning, and then mid evening. So
so much.
I was just curious if there's something specific grain, if there's specific grains they should avoid during that time or specific medications. Because it's pretty much sugarcoating it if you're just giving them pain med but not helping the actual problem. So
Absolutely, absolutely. And you can make an argument that giving, bute or other nonsteroidals could potentially be making the problem worse, because nonsteroidals actually inhibit that protective barrier in the glandular stomach. And so it's a bit of a chicken or the egg. I will say this, in many patients that I am treating for gastric ulcers, if we do not have a clear indication where they need to be on a non-steroidal anti-inflammatory, I will try and remove the non-steroidal anti-inflammatory while we are treating the gastric ulcers, so that we can create a effect more quickly.
okay.
So I do try and remove non-steroidals as much as possible. As far as from a grain feeding, in general, it is best to feed a hay meal prior to a grain meal. So most horses love grain, right? I mean, a lot of them really want to go for it. It's tasty. And so if you put grain and hay in the stall at the same time, a lot of them are going to go to the grain first. And so in a perfect world, we would always offer hay prior to grain, because it's going to cause them to chew. So we are going to have that more saliva production, which is going to buffer the acid. We know that when we then feed grain causes the acid in the stomach to be more acidic. And so if we have a hay barrier already in there, we have a little bit more protection within the stomach and them already prior to that grain meal.
Okay.
Alfalfa in and of itself, with that high calcium phosphorus ratio, is like taking Tums when you eat. So if you know that every time you have spicy food, you get acid, you get heartburn, alfalfa is like taking Tums. And so it can help in that same combination, and is that it will also buffer our stomach acid a little bit more. And then from a grain standpoint, certainly grains that are higher in starch, like sweet feed, the more molasses, the sugary grains, those are also going to make acid more acidic in the stomach. And so avoiding really sugary grains, for not only just from a gastric ulcer standpoint, but also a nutritional standpoint, is really important. There are a couple products on the market. One is made by Purina, and it's called Outlast. And Outlast is a really wonderful product. It's in some of the Purina feeds themselves, but it's also something that can be purchased and fed as just a supplement, and can truly do a really good job decreasing gastric acid production in the stomach, and is a really great thing from a maintenance perspective or prevention perspective. I have been very happy with that product, but I didn't want to get too product focused in this lecture, because I think it can open a can of worms. But that is one product that is on the market that does have a lot of scientific evidence behind it, showing that when this product is fed and we measure the acid in the stomach after, we do see a decrease in the acidity. So I think from a grain perspective, Outlast is a great addition. I hope that answers your question.
Awesome. Yeah, no, thank you very much. I appreciate it.
Absolutely.
Okay, any other questions? Okay, I did make a couple notes during your presentation. So you mentioned that endurance horses are overrepresented as sufferers from ulcers. What can endurance riders do to help balance that? So obviously, while they're in the middle of a ride, they're not going to stop and have some nibbles, as much as that would probably be great. So what can they do, like perhaps in the time leading up to an event or after an event, to help minimize the impact?
Yeah, so, and I'm going to speak to this not only from endurance riders, but also trail riders, because I recognize that trail riding and endurance riding is completely different. The only reason I'm going to tie them together here a little bit is because some people will go out on a trail ride for 3 or 4 hours. And in that capacity, we are, from a duration of ride, we are going to include them, kind of talk about them similarly, because I do see a lot of trail horses that also have ulcers, and people go, but how do they have ulcers? We don't, you know, they have such an easy lifestyle. And so one of the things that from an endurance perspective that they can do is having them on some of these preventative measures. So omeprazole at a preventative dose prior to competition will help make the acid that's in the stomach less acidic. But just having good management strategies outside of our endurance training, so outside of our days where we have long rides, having access to food constantly, doing these other management changes that we talk about will help on those days as well. Because if we have a good environment 90% of the time, then the 10% of the time that we are on our long ride, the body is able to heal itself during those off periods. Because squamous ulcers, even without any medication, even without proton pump inhibitors, without anything, if we can change the environment that is creating the ulcer, we can heal the ulcer without any medication. But you have to be able to heal the environment. And so when we can't completely change the environment, because sometimes it's absolutely impossible to be able to make it a perfect environment for the stomach because it would be impractical, thus we have to use some of these medications. So using proton pump inhibitors at a preventative dose so that when we are on long rides, the body can heal in between would be the best way. Does that answer your question, Jen?
It does. Thank you. And so for the glandular ulcers, I hope I got this correct.
Yep.
The misoprostol?
Misoprostol, yeah.
Misoprostol. How does that work? Does it sort of, okay, for my very non-veterinary imagination here, does it like create a physical barrier in the glandular stomach, or is it absorbed in the bloodstream like the omeprazole?
It is absorbed in the bloodstream like the omeprazole. It travels back to the cells of the stomach, and rather than omeprazole working on the cells that are secreting acid, it works on the mucus cells in the stomach and causes them to produce more mucus. And that mucus is the protective barrier. So it increases the protective barrier, but not by being a physical barrier itself. It creates a physical barrier by acting at the cellular level. So the thing that is that in and of itself is the physical barrier is sucralfate. So sucralfate is the one that we talked about being inhibits other medications from being absorbed because it actually creates a physical barrier. It's like for patients that have those grade 4 ulcers that are just really angry looking, sucralfate will work on the squamous tissue as well as the glandular tissue. It works in both because it does just create kind of like a coating across the stomach.
Okay, so it's essentially a Pepto-Bismol sort of.
Sucralfate is.
Sucralfate. Okay.
Yes.
Wonderful. And then if we decide to, if our horses are, we want to change the environment in the stomach a little bit and feed alfalfa, what is the difference between loose alfalfa and the pellets and the cubes? Obviously, there would be different levels of chewing involved.
That is the answer.
Okay, so is there any benefit to feeding pellets and cubes simply for that sort of Tums effect, or is it better to feed the alfalfa to increase the saliva production?
So hay, like long stem forage alfalfa, true alfalfa in hay is always going to be the best because of the chewing action that it provides, because of the fact that it is a long stemmed forage. It will create a better physical mat in the stomach as well. However, alfalfa is not available everywhere. Sometimes it's exorbitantly expensive. There are various things. So if we cannot get a hay that is either, has alfalfa in it or is pure alfalfa in and of itself, then certainly hay cubes that are soaked or alfalfa hay pellets that are also soaked are still acceptable because yes, we will still get that benefit of the calcium phosphorus ratio. We just will lose the chewing action as well. So if you have the availability to get alfalfa hay, but it's exorbitantly expensive and is not something, or your patient is such that they get very hot on alfalfa, or they get, it's too rich, and so they get, other GI issues from it. What I recommend is just having a couple bales of pure alfalfa, if you can get it, and feeding them half a flake prior to your ride. So they get that while you're tacking up. If they're eating that alfalfa hay, it's not a large volume of it, so we minimize the effect on the rest of the GI tract, but they get that benefit of chewing, they get the physical barrier in the stomach, and they get that calcium phosphorus ratio prior to riding. And when, if we have an empty stomach and the acid is splashing around, that's when we see those squamous form. But yes, in general, long stemmed alfalfa is better than pellets or cubes, but still both have benefit.
Okay, great. Does anyone else have any questions for Dr. Golden? And let me move. So this is her contact information, and you can jot that down. We'll also post this in the event page so you can refer back to it. Thank you so much, Dr. Golden, for being here. And we do have, as all good webinars and podcasts do, we have that one question we ask all of our presenters.
Oh no.
So what was your favorite book as a child that it maybe inspired you to become a veterinarian, inspired your love of horses? But we just think it's interesting to see sort of what our vets love to read.
Well, when I was a kid, the Thoroughbred series of books was definitely my favorite to read. I don't know if I had a specific book in that series that was my favorite, but I certainly loved reading the Thoroughbred series as a kid. Those were my favorite.
Wonderful. That works. Well, typically at this point, we talk about our next seminar series, but our speaker had a conflict. So we are thinking about what our next topic will be in September. So if you have any ideas, please go ahead and either drop them into the chat or drop them onto this August event on Facebook, and we will look into those. We have a whole list, but just trying, when you have so many good topics and you wish you could do it every week because there's just so much to learn. So, and then we just also wanted to mention we have a few events. If you are local to us, we would love to see you come out for them. Our tack shop and farm tours are next Sunday, the 21st. On August 27th, we are participating in the NBC Universal National Campaign to clear the shelters. And of course, our fall festival is on Saturday, September 17th. So we hope that you will consider coming out and joining us if you are local. And last opportunity to ask any questions of Dr. Golden before we sign off for today. Dr. Golden, thank you so much. Your presentations are always so informative and make me regret not going to vet school, although
they're so much more fun to do in person. It's so hard talking to a computer screen.
Yes, but it's so wonderful.
Thank you so much for your time.
You're welcome. Have a great day, everyone.
Okay,
wonderful. Thank you, everybody, and we'll see you next month.
Bye.